Ready? Okay, with that, we will go ahead and get started with our second presentation for the evening. We are at SCPHA are pleased to welcome our panel. We have three speakers with us this evening. The first of which is Cheryl Anderson. Anderson is the Director of Pharmacy Services at the Department of Health and Human Services. She has over 40 years of pharmacy experience. She is also a graduate of the USC College of Pharmacy. She has served in state government for 20 years. She is currently serving in the capacity of president of our board for South Carolina Pharmacy Association. She's on the advisory committee for the SC Midlands Technical College Pharmacy Technician Advisory Committee. That's a, man, they need an acronym. She was the 2018 recipient of the South Carolina Pharmacy Association's Generation RX Award of Excellence and a 2019 nominee for NABP's Hal Rogers Beacon of Hope Award. She has authored most recently the 2019 South Carolina Law Review Journal, utilizing pharmacists and education services to promote proper use of opioids across South Carolina, and 2020 American Pharmacists Association abstract community pharmacy interventions to prevent opioid adverse drug events. She's been a lifetime member of SCPHA since 1981. She enjoys working on completing her behavioral health advocacy book for publication, cooking, spending time with her husband and family, and enjoying the newest addition to the family, Annie. Their 2-year-old rescue dog. I should also mention that she was the first female administrator and inspector for the Board of Pharmacy. Yes, and carrying the torch. We did it. So carrying the torch and advancing the cause, we have Dr. Tracy Collier with us. She's administrator and chief drug inspector of the South Carolina Board of Pharmacy. In her time on the board, she served in numerous committees and task forces for NABP and currently serves as the District 3 representative on the NABP Executive Committee. Before her work on the board, she worked in a variety of pharmacy positions for 17 years with Kaiser Permanente. And she earned her Doctor of Pharmacy from Campbell University. Also with us tonight, we have Dr. Julie Hernandez. She's the Director of Pharmacy for Healthy Blue Medicaid and has over 25 years of pharmacy experience. She's a graduate of Butler University in Indianapolis. She began her career in hospital pharmacy. She spent 17 years in long-term care, moved here in 2007 with her family to South Carolina, and has worked with Medicaid managed care since 2015. She's a member of this association and also the Academy of Managed Care Pharmacists. She lives in Charleston now. Thank you for making the commute with her husband. She enjoys all things the Holy City has to offer. She has 2 boys in college, and they're both following their parents' footsteps as soon-to-be medical providers. In her spare time, she enjoys playing pickleball with friends, helping rescue feral cats, and working on home improvement projects. We already covered this. None of us are getting any money. This is worth an hour and a half of ACPE credit. Again, that is claimed on the Lecture Panda platform that we use. You should have an email associated with that. And this is directions on how you claim this. And tonight's presentation and materials are available on Lecture Panda as well. Our objectives for this session is to describe how the Pharmacy Access Act affects the scope of practice for licensed South Carolina pharmacists, to describe how to enroll the South Carolina Medicaid as a licensed pharmacist provider status, y'all. Identify the medical billing codes reimbursed by SC Medicaid and their managed care organizations. We have 3 assessment questions. The first is, when dispensing oral contraceptives via the Pharmacy Access Act, which of the following must be given to the patient in writing? You can see the potential answers there, and we will answer these by the end of the session. Our next question is, which of the following procedure codes can pharmacists bill for through the SC Medicaid program under the Pharmacy Access Act? and we will know that by the end here. And then how can I contact the managed care organization if I have questions about credentialing and billing? So that will be answered as well. We also have some time for questions, reflections, and outbursts of righteous indignation at the end. So welcome, panelists. Thank you for being here.
It's just down. Okay. All right, well, thank you, everyone. As he mentioned, my name is Tracy Collier. I am the administrator for the South Carolina Board of Pharmacy. I walk when I talk, so please forgive me. If you can't hear me, just tell me to move back over. It's going to be, I've been like, had a little rash since he told me I couldn't move earlier. How am I going to talk and not move with that? So please bear with me. But thank you to the association for having us with this. I think this is important information to get out. So thank you very much for the invitation. As Dr. Baker mentioned earlier, the Pharmacy Access Act was passed in May of 2022. And what this does is it allows the pharmacist to dispense self-administered oral contraceptives or to administer injectable hormonal contraceptives. And that word dispense is very key as the bill was going through. And I think that's part of what some of the access issues are, that it was very important to other stakeholders that the word dispense was there and not prescribe. Because for those stakeholders, pharmacists cannot prescribe, they can prescribe. So that's kind of where we are. So we do use the word dispense. It's used in the bill as well as the protocol that came after. With that, so pursuant to the Act, the Board of Medical Examiners and the Board of Pharmacy then issued a joint protocol. The statute or the law itself was pretty prescriptive. So the protocol is honestly a lot of cut and paste because there really was no wiggle room with that. They were very prescriptive in their statute. So what does this mean for us? The fact that South Carolina has a Pharmacy Access Act. So in South Carolina, pharmacists who have met the training criteria and they have a standing order from a physician that they partner with, they may then dispense self-administered oral contraceptives, or they may administer or injectable contraceptives to a patient who meet the criteria. And we're going to talk a little bit about the criteria as we go through this program. So training, according to the statute, the training is anyone who has graduated from a South Carolina accredited pharmacy school since January of 2021. The legislators' thought was that that would have been included in the curriculum at that point, so that would be acceptable, or have completed a program that has been accredited by ACPE or another health authority that's very specific to the dispensing of the oral contraceptive. The law actually uses the verbiage a certificate program. The committee who put together the protocol did look at that. And if you look at a true certificate program, I believe it's about 15 plus hours through ACPE. And the thought was of the group putting together the protocol is they really want to decrease the barrier to access. So they took a very liberal approach to the word certificate because there are programs who will offer some training and they'll give you a certificate at the end. So they did take a very broad approach to that. So it does not entail the 15-hour certification that ACPE offers. You do have to, if you are following the Pharmacy Access Act and you're dispensing via this protocol, you do have to do 1 hour of continuing education per year. I cannot tell you how many calls I got this year that said, I dispense birth control pills all the time. Do I have to have the CE? And the answer is no. And so we try to make it very clear on all of our communications that it's only if you are dispensing via the protocol that you need to have that specific hour of continuing education. These are just some examples of programs that would meet the requirement for the initial training. This is not an endorsement of these programs, nor is it an all-inclusive list. It's just to give you an idea of the type of programs that are out there that would be acceptable. So who is eligible to receive oral contraceptives in the pharmacy setting? So anyone, female who is 18 years or older would be eligible, or if you have a patient who is under 18, but you have some evidence from a previous practitioner that they have been seen and they've received oral contraceptives in the past, or they've had the injectable in the past. And again, the protocol that the boards left it pretty open. They didn't want to be very prescriptive. So anything that the the patient can prove they've had this in the past. It could be a prescription label, it can be a copy, it can just be a previous ABS from a visit. So it's not, it can be electronic, it can be paper. It's not a heavy lift for that. Any kind of proof that that patient can provide that they've had that in the past is acceptable. So with the patient screening, and I handed out a couple things that just for references we walked through, because we try to get everything on one little piece of paper and there's no way you can see it on a screen. So this is just a snapshot of what the initial screening looks like. So when you have a patient who comes in and asks for oral contraceptives, there is an initial screening for that patient the first time they come in, and then again every 12 months. With that, it has to be screened. So here's a copy of the form, the top of the form that they would fill out. And like I said, I passed some out so that you can see them. But there's a large number of questions. They're all color coded. It's kind of like putting a puzzle together. With that, they're color coded, and then there's an algorithm on the back that helps you determine what those colors all mean. So the patient comes in, you get 12 months later, you can renew the assessment. But within 24 months, they do have to have some verification that they have seen a provider regarding this. So if the patient comes in and they filled out this screening, and if you look at your yes and no answers, they're color coded, you flip to the third page, that also is color coded. And so you can tell based on their response on their questionnaire, whether or not they are eligible. And I wrote this down in big letters because without reading glasses, I can't read this. So if you have a patient who is diabetic and they have neuropathy or retinopathy, you know that they are not going to be a candidate for the pharmacy to provide oral contraceptives, combination contraceptives for that. So you can use that to make your determination. So if you do decide that the patient is not a candidate for oral contraceptives to be dispensed from the pharmacy, the patient has to have a copy of that encounter. You have to document and provide the patient with why you could not dispense that contraceptive to them. And then you want to refer them to their primary care physician or health department, whomever it may be, in order to see a practitioner for that. And so again, here's just a copy, a snapshot of the actual screening questionnaire. It does have that you have to get a blood pressure, and it has, the question came up when we did this a couple weeks ago in Greenville, because it does say the blood pressure reading must be taken by a pharmacist with that. And that's a question when we go back and relook at this, if the law changes, can it be someone else in the pharmacy? The true intent was it's not a machine that somebody sits down and it automatically inflates, or they don't say, this is my blood pressure at home and you use that. It could have been their blood pressure at home 3 years ago. We don't know with that. And so they want to make sure that a healthcare professional is actively taking that blood pressure at the time of consult. And again, there are specific counseling points. Like I mentioned at the beginning, the statute itself was very prescriptive in what is required. But you have to counsel the patient on the appropriate administration and storage, any side effects that they may have, the need for backup contraception, when to seek emergency attention, emergency medical attention. You also have to make sure that you're counseling them on the risk of sexually transmitted diseases and how to prevent those. You have to provide an after visit summary, and they're again very prescriptive in what had to be contained in the after visit summary. Again, the importance of seeing a practitioner annually, the effectiveness of the contraceptive and alternatives, a copy of the encounter, the description of what they're getting, or again, the basis for not dispensing the contraceptive, how to apply for South Carolina Medicaid, effectiveness, you have to counsel them on abstinence, and then again, the sexually transmitted diseases. Just to reiterate, it mentions it multiple times in the law that you really need to counsel the patient to see a practitioner. If there is any patient that you feel may be subject to abuse, you're required by this law to refer them to the appropriate social service agency, which I think this is really new for pharmacy. And then again, if they have a practitioner, if they have a PCP, you're required to notify the PCP and just report to them the dispensing. Record keeping, have to keep it for 10 years with that. So all the patient information, a copy of this assessment has to be kept. This all can be kept electronically. Nobody wants to keep paper for 10 years. So if you have electronic means, you can do that. All the information about what was dispensed, the date, the consent form, any adverse reaction or complications, all the information on the pharmacist. So the pharmacist's name and license number, and then also a copy of any notification that was sent to a primary care provider. Liability, this is where everybody stops because they're like, I don't want to be liable for that. The law itself says that a pharmacist who follows the protocol is not liable for any act of omission. You're not liable for professional, you're not going to show up at the board with that. It has the same verbiage regarding a practitioner who signs a standing order as well. And that is really what I have. That is the Pharmacy Access Act in a nutshell. Yes.
There is a question. Do you have an idea of approximately how many sites in South Carolina are dispensing oral contraceptives under this program?
I'm not aware of any. That doesn't mean it is not, because they're not required to report it. But from our inspectors who have been going out to the facilities, have not seen it yet that they've told me. Yes, ma'am.
So I spoke with you about Nephron possibly doing this for the employee pharmacy.
Mm-hmm.
And I got a lot of pushback from the physician because we use Marathon Health for their physician, and I was trying to get an agreement with him and the employee pharmacy. Do you have any like advice on like getting like providers to kind of like agree to this? Like,
I don't, and I'm not sure if, and I was actually just talking to Cheryl before this, when the protocol was finalized and we put it out for public comment, the only comment that we got was from physicians and saying this law should never pass. And I'm like, well, that train went out of the station about 6 months ago. That's not where we are.
Basically, like send them to me, like that's my job. Like,
right. So I do not, and I think based on back to what Dr. Baker said earlier about the legislative initiatives, I think that has been the barrier to access, is that finding that provider that is willing to partner. I know when we had, so for example, the immunization protocol, our chief of the medical board is fine with that signing off on that. She was not fine with signing off on a blanket for oral contraceptives or injectable contraceptives. So I think that is a barrier. This is the world according to Tracy, my soapbox. I think educating other providers about what pharmacists can do is just key for the pharmacy profession. Like I said, this is not a board of pharmacy view. This is Tracy's view, but I think just educating not only practitioners but patients what pharmacists can do. I know when I worked retail, the most common question was for Q-tips. So making sure that they realize, the skills that we have and the education that we actually have. But it is an uphill battle.
it's unfortunate. Everyone was really on board, and I was like ready to go, and then the provider's like, no.
And that's what we found pretty much across the state. So back to Dr. Blake's question, I don't know of any who have been able to institute it, because I don't know of anyone who has been able to partner with a practitioner.
I think you just answered this question, but there's Patty's asking, since there was a liberal approach to certificate training program, what's the likelihood of taking the liberal view of standing order? Say as an example, the state protocol acts as a standing order, but I feel like you just answered that.
Yes, it is. So the Board of Pharmacy does not allow standing orders either. We don't recognize standing orders with that. So it's going to have that piece is going to fall on the medical board to provide that. And I think that might be a hard push. Right.
So it sounds like, I think this wrong, you've got to have a chiropractor agreement along with the protocol board to engage. Like, let's say there was a disease state for which there is not currently a mention in the Access Act. Can a pharmacist and physician create a collaborative practice agreement to treat diabetes in some way that delegates that up? I mean, does this allow a broader or narrower ability of pharmacists and physicians to collaborate?
So currently, we do not have any language for collaborative practice other than a policy. And the policies worth about as much that piece of paper as you have in front of you. But what it does, it gives some guidance. I will say that, the board is looking at, let me guess, with my board members, looking at putting that collaborative practice in regulations for the next year. So right now it's a guidance document, but there is nothing in statute or regulation that allows pharmacists to prescribe or to change medications, et cetera.
So it's neither allowed or disallowed, or would you say that?
I would say currently it's neither allowed nor disallowed. It is enforcement discretion. It's become my favorite word.
Because like what I'm getting at is like theoretically, if a provider said, I don't like this protocol, let's do this instead, like, could you argue that they're not providing a collaborative practice agreement under the Pharmacy Access Act, but they're providing a collaborative practice environment under the gray area that is neither allowed or disallowed?
Yes, I think you could argue that. I don't know, technically. Like, I actually read the CPA policy today before I came. I was like, somebody's gonna ask this question with that. I think you could, because the collaborative practice policy is pretty broad. And I think that was intentional as well in those discussions. So I think you could, it just depends on, but if you have that same issue, is the provider gonna be comfortable with that? Actually, I'm gonna back up. The collaborative practice agreement has to be with that particular provider's patients. So so Dr. Anderson and I could partner with a collaborative practice agreement, but I can only do that with Dr. Anderson's patients, and I would have to do Dr. Hernandez's patients. And so it would take multiple agreements. So in an outpatient pharmacy, it might be very challenging versus Dr. Anderson gives a blanket, standing.
So here is, as soon as one provider, a practitioner
Correct.
says, yes, you're good to go regardless of whether or not that patient and provider have a.
Correct. Correct.
See, you would need agreement from every single provider of, like, you would have to go.
Through a collaborative practice agreement, you would. For this, if you had a chain pharmacy and you had a medical director who was a South Carolina licensed physician, that medical director could do a standing order for every facility in that chain.
So all it takes is one to agree. You just can't find one to agree.
Correct. It's the liability. I think it's the liability that really
Yeah.
scares them. That, and again, it's the education piece, I think, is a gap for pharmacists educating providers and what you can use. Yes, ma'am.
For the liability of the pharmacist, does that apply to the physician who signs or
It does. There's identical language regarding liability for the practitioner as well as the pharmacist. Great questions. Anyone else? All right. Thank you all very much.
Francis, did you have one more for Tracy?
My thought was, I have a reason why I can't dispense some interaction. What's to keep you from going across the street and saying, oh, no, I don't have that sort of disease state or whatever?
Absolutely nothing. And in that same thought process, there's nothing to keep me from going from this position to that position. Once I've gone to this position and they're like, I'm not comfortable with it, and to be honest, today with all the teledocs popping up, it's a phone call a lot of times.
Great question. So for those of you that are online, the question was, and correct me if I'm wrong, that what stops the patient from going from one provider to the next for getting what they need or they want? And Tracy said there really isn't anything that happens in telemed now. So is that basically the question and then response? All right, thank you. Well, first, I have to wear two hats tonight. So as your association president, I want to welcome everybody and I want to thank you for being here. It's the second rally that we've done. We were in Greenville and we had a small group. We had less than 24 people, but we had a ball. We had some great questions and we came back with some great ideas. And for that, I'm very grateful. I even reached out to some of you in this room because there were some ideas about how can I actually get involved with the Access Act if I'm a boutique pharmacist. And what I mean by that is I don't have a pharmacy home. And I'm going to use you, Lynn, because I used you and Francis as an example of, someone like you that has the relationship maybe with a physician, nurse practitioner, or PA. They could come on board with you and actually be able to be a provider through Medicaid, and Lynn and Francis would be reimbursed from the pharmacy standpoint, but they could also contract with that pharmacist at an hourly rate or whatever, a portion of the reimbursement. So this is what we're going to talk about tonight. So now I'm going to take off my association hat and I'm going to put on my Medicaid hat. And I really get excited about this because I went back to Medicaid right when this was about to pass. And when the agency director came to me and he goes, there's a chance, and Medicaid is in this Pharmacy Access Act piece of legislation, and we are going to be a payor. And I said, well, let me read the whole piece of legislation because that's the part I really love in what I do. And I read it, and there was another commercial payer that was in that piece of legislation. Well, they ended up backing out. And the agency director came to me and he goes, Cheryl, what do you want to do? What should I do? And I said, well, sir, I think you ought to stand up for your pharmacists. Your pharmacists are there to give access to care to our members. And I'd like to see you keep Medicaid in this bill. And we did. So I'm going to talk to you a little bit about tonight about how to become a provider with South Carolina Medicaid. So Tracy gave you the basic overview of when it came into effect. So I'm going to take you from September 18th forward. So on September 18th, we opened up this year, we opened up enrollment for pharmacists. So I want to kick this one off. So we've got about a month under our belt. Do I have any guesses of how many pharmacists have started the enrollment process? There's no wrong answer. 2, okay. Anything? None? That's a great one. One more guess. 1, okay. It's actually 9. And so really, y'all, that is great because when we were 2 weeks ago in Greenville, we weren't there. And I'm proud to say as of this afternoon, we have 3 providers that have made it through totally, and they are now Medicaid providers. So cheers to us because we have 3 providers. Every morning I go in and I go, how many do we have? And they go away, Cheryl. It's not like they're multiplying like rabbits, but but yeah, so we have 3. So this has been really good for us, I think, at Medicaid. We only anticipated probably having about 35 pharmacists enrolled the first year. So I'm really proud of the 9, and I'm glad y'all came with low numbers because when we were in Greenville, it was a much different thing, and I was sort of taken a little back, but we had just started. So we're proud to have the first 3. Do not have any claims yet that have been filed. So I think within the next week, we'll be able to say that we've had some claims. And I have asked Brian to do a spotlight on what Medicaid has done with the number of providers we have enrolled and how many claims we have in the coming months. So I think keep looking out on social media. He'll be blasting that out for us. So with the Pharmacy Access Act, as Tracy said, there is sort of an ordering, rendering, and a pay-to provider. So the ordering is going to be that prescriber, either an MD, a PA, or a nurse practitioner that does the standing order. The rendering is going to be you, the pharmacist. The pay-to right now is the pharmacy. So I want to make sure to leave you with those terms of ordering, rendering, and pay-to providers. So in order to do this service for our Medicaid patients, and I've got Julie with me here tonight, and she's going to talk about the MCOs, because at South Carolina Medicaid, We have about 1.2 million citizens that we take care of. And only 20% of those are fee for service. The rest are serviced through our 5 MCOs. And so I want to leave you with a flavor of the overall project and plan that affects fee for service and MCOs. And then I want you to hear about the MCOs because that is an opportunity for you to service those patients for us too. So I also want to let you know that we do this for our full members that have the full benefit, and also those that are enrolled in family planning, which is a limited benefit. And again, pharmacies are the only one at this time that can be reimbursed. Procedure codes, something a little different for us. So when we got together, I'll never forget when we got the legislation was passed, and every couple months we get together, all of us pharmacy directors, and we're a lively bunch. We got in there and everybody had a different opinion. Should we pay it on the pharmacy side of the house? Should we pay it on the medical side? And you got to remember, I've got 5 Julies, okay? And they might be over more than just South Carolina. So they have opinions because they've done things in other states. I must say they do. We got a meeting coming up. But we really love each other. Maybe too much at times. So we came together and we batted this thing back and forth. And I mean, it was like playing baseball because, you know, some of the directors said, no, we want to pay it on pharmacy. Let's try to make up a dummy code to make this thing work, because we as pharmacists have been known to use a lot of dummy codes, right? And dummy NDCs to just make that claim work, right? So I sat back and I let the 5 of them go back and forth. And then I said, hey guys, what do you think about us doing it on the medical side of the house? And then we all stood back and said, hey, we are the only payor that's in this legislation. Let's make a difference and make sure that our pharmacists are medical providers. So we decided to put it on the medical side of the house and not the pharmacy side. So procedure codes are new to us. And I think that's the part that is scaring pharmacists. And that's the part that I want to leave you with. This is new, but it's going to be before us in the years to come. So don't be scared of it. Embrace it, learn it, and do it. So these codes are, and I want to tell you a little story about these codes because I go over and speak at USC at my home school all the time. And I give this same lecture about the Pharmacy Access Act. And I did it last week for Dr. Cease. And when we did this, we decided to do what some of the other states in the nation did. We decided that we needed to have appropriate codes. We knew that we were going to have new patients. We wanted to make sure that we took care of our established patients down the road, but we also wanted to make sure that we could assess our patient. And if it came to a point that we weren't going to be able to dispense to that patient, that we would reimburse our pharmacists. And I think that's the most important thing. So you'll notice that there's codes, and you'll notice 99202 is the new patient visit for only 20 minutes. 99203 is a visit for up to 44 minutes. And I know this question is going to come, so I'm going to go ahead and head it off at the pass. The rates for those 2 codes range between $60 and $80. Pharmacists are reimbursed at 80% of an MD rate, which is parity with nurse practitioners and APRN, with nurse practitioners and PAs at South Carolina Medicaid. So to me, that's a clap for the room too, because we are recognizing ourselves as being paid the same as the other specialists. And we've never had that. And, you know, there was a chance that there could be another payment regime, but we went with 80% of the MD rate. You'll notice at the bottom, there's a urine pregnancy test. You notice Tracy didn't mention any of that. That's not in the protocol, et cetera. But what I did learn from my peers around the nation that have already developed this initiative is that we as pharmacists, we tend to take everyone's word, but we worry about liability. So I thought about it and I said, I'm going to pull and see what the other states are doing. Most of the states around the nation do allow their pharmacists to bill for a urine HCG. And that allows you to have that reassurance that that answer on the questionnaire is truthful at that time and point, because the patient is filling out the questionnaire. You do ask them when their last menses was. You do ask them if they've had any unprotected sex since their last menses. But we as pharmacists, we know we always like things to be 100%. So I thought it was fair that we add in a urine pregnancy test. So South Carolina Medicaid will reimburse you for a urine pregnancy test. In addition, you're going to have those patients that are going to be those new patients that you are going to probably spend the 99203. So you're going to spend that 30 to 40 minutes with. And you're going to get down to that question that says, do you have a history of deep vein thrombosis? And they go, yes. Well, as a pharmacist, you're going to pause. Or there's going to be that patient that is going to say, hey, I have a history of breast cancer. And you're going to say, pause. And then you're going to say, I just spent 30 to 40 minutes. Am I going to get reimbursed by South Carolina Medicaid? The answer is yes. So we do, and you'll see it in the next screen, we do have the corresponding codes for you to use that show that you were counseled, that you counseled that patient. So I think that gives you a reassurance to go through the thorough process and know that you can and must walk away when you have that patient that needs to be sent to another healthcare provider. Any questions on that? Because it's a little different for us as pharmacists. Now, with the urine pregnancy test, there is a little disclaimer. Kim told me to make sure to tell y'all, you got to make sure you have a CLIA certificate of waiver to bill that procedure. But I think most of you that have gone through some of the COVID testing already have CLIA waivers, is what I found out. So that general counseling code I was talking about, here are your diagnosis codes. So when your claim comes through our system, okay, you are going to be the rendering provider. You're the pharmacist. Okay, so the claim is coming through. It's got a procedure code. It has got to marry up with one of these diagnosis codes. So if it doesn't, you're going to get a reject. Just like the point of sale over here on pharmacy, it's going to reject and tell you you've done something incorrectly. So you need to make sure that the diagnosis codes match up with the procedure codes in which you're billing for. Any questions about that? And I think I've told Brian that I think we need a whole lecture on medical billing. I think we need to go through a whole 1500 form and go through the different types of platforms so that we as pharmacists know exactly how to do this. Yes.
So this general counseling does not have to specifically relate to hormonal contraceptives. We could counsel a patient with anything and get reimbursed, or no?
No. So the question for those that are online, the question is, can I use that general counseling code and for anything, for any type of counseling? The answer is no. This is strictly for the Pharmacy Access Act. So it's only for these procedure codes, and these diagnosis codes are relevant. Someday, futuristically, I'm in with you. Okay, that's what I'd like to see. But right now, it is only for hormonal contraceptives. Great question, though. Yes, ma'am.
You said this is only for under the Pharmacy Access Act. So like, if I got a prescription for contraceptives and still like walk through with the patient and I administered a depot shot to them, for example, did I bill Medicaid for that?
Yes, as long as you go through and meet all the requirements for the Board of Pharmacy.
But like,
Okay,
okay, that makes sense.
okay. Repeat that question. Yeah. So her question is if she gets a prescription and she administers the depot, if she has gone through the protocol and you have gone through all the, and Tracy, you correct me if you're not happy with that answer.
I believe her question is if someone just has been to a different provider and they bring in a written prescription for depot
And then she administers it.
Yeah, like that
No.
I bill for the administration.
It's not
No.
It's not based off the protocol.
Not off the, if you're not using you must use the protocol. So if you don't go by the protocol, you cannot bill South Carolina Medicaid. Great question. Thank you, Tracy. Anything else? All right. We do have a link in the PowerPoint of where you can go for the current fee schedule. And it will actually bring up those codes and you'll be able to figure out 80% of those codes. So you'll know exactly what will be reimbursed. And that was the great example I used because when the act passed, I called Tracy and I said, Tracy, what about our pharmacists that really don't have a pharmacy home? How are they going to execute this? And she goes, Cheryl, they just can't. They have to have, the pharmacy has to be paid. There has to be an ordering physician or a nurse practitioner or PA, and then the pharmacist can render the care. So this was the,
Oh, sorry.
Go ahead.
They also have to be able to dispense. They also have to have the product, and the only way to have the product is to be in a
perfect. And that's where I called Lynn up and said that was a perfect example because we had a lady that is from your area and she goes, wow, how can I do this? And I said, that's when you go to your local pharmacy and see with your pharmacy owner if you could come on board as a consultant or as a pharmacist and whatever deal y'all work out and be able to do that. And then you do, like Tracy said, you do have that product to also dispense from that pharmacy. So Francis and Lynn, thanks for letting me use y'all as an example. Enrollment. How long does enrollment take at South Carolina Medicaid? Up to 30 days. I was surprised it was that short, y'all. And Julie and I've had this conversation because I think when Julie gets up here, when you ask her that same question, she's going to give you a different answer. And you're going to, yeah, I'm going to look pretty good after Julie gets up here. And Brian, you need not talk, and neither one of y'all over there, because I got two other MCO pharmacists over there. So when you go, this checklist is wonderful. And what we've done is we've made 2 videos that we have out there posted. One is to show you how to bill, and one is to show you how to enroll. And the one thing I know, again, is us as pharmacists, we are very exact and we go 1, 2, 3, 4, and we check the boxes. We have a PowerPoint out there. One of them's 56 slides and one's 34. And if you go by that PowerPoint and you do your enrollment, I'll guarantee you will get enrolled because I sat there and did it. And you can actually, once you get into the system, and I'll show you the number that you get, you can actually come out of the system and come back in and finish your enrollment. But I do want to encourage you to use the tutorial tools that we put together because it's something different for us. And I know that if I went through it and I could do it, everybody can do it. So I feel very confident that there's no reason you can't get enrolled. You need a few things when you get ready to sit down. It's just like going and renewing your driver's license. You need to know your name. You need your social security number, and you need to have an MPI number, okay? So if you don't already have an MPI number, you need to make sure you go ahead and get your NPI before you start your enrollment. It will also ask you for a taxonomy number. And that one is that 1835, the 0000 that ends in an X. That number is static for us at South Carolina Medicaid. So that is the number you will use there. It will also allow you, and in most of the places, you can use your own personal email address for us to contact you. It will ask you, though, if you have a trading partner. So that means if you have anybody that is going to be doing your electronic data exchange for you, because you can use a vendor, you can use our website where you can go on and use the billing tool, or you can use the paper 1500 CMS form, the medical form, and mail that into the agency. I think most people are going to use the software that they have from their vendor, or they're going to use what we have on the Medicaid platform. Now, This is just a small example of how what you'll see when you get to the provider enrollment website. We have gone through and each one of these slides say, click here. So if I'm telling you, I will give out my personal cell number and you call me if you cannot get through and get enrolled. It's as easy as becoming a provider. So you click to apply and you keep going. The few helpful hints I do want to give you is this graph is very helpful. When you're prompted to put your enrollment type, you need to put individual. For provider type, you need to put other medical professional. For primary specialty, you put pharmacist. And for subspecialty, you don't need to put anything. So these seem to be the areas that people trip up the most on when they are doing enrollment. Next, once you've completed the information, you'll receive a reference ID. And if you can see that reference ID, you can tell that it's state government because that is the longest number with more digits and alpha characters than I care to write down. But that's the number you're going to get. That is your reference ID. So if you start your application and you want to come back in, you need to get all the way to the point that you get a reference ID because that is going to be your key to get back into the provider enrollment. So this long, take a screenshot, write it down, because if you're like me, if it's the end of the day and you're tired and you're trying to enroll after you've worked all day, that last RT at the end is going to turn into TR. So have a backup because we can't go in naturally and tell you what that is, and you'll have to start over. And nobody wants to do that. So just make sure the reference ID is critical to get you back in. It will also ask about your affiliate pharmacy information. Now, this is very primitive. So this is typical state government. We don't have a form yet, but that's on the horizon. We're going to ask you on a piece of paper to put the name of the pharmacy or pharmacies that you want to be affiliated with. So if I have only one pharmacy, then I'll do all the information shown for that one pharmacy. I'll print my name, I'll put my phone number, that lovely reference ID again, the signature and the date. Then I will submit that in to Medicaid and you'll fax it in, okay? But if you're a relief pharmacist, whether you're with an independent or if you're with a chain, you will need to put each site that you want the pay to go to. So you will list each one of those on that same piece of paper or one or two sheets. So I know that sounds very primitive, but that's what we've got right now. So it's as basic as the name of the pharmacy, the address, their Medicaid legacy number, the pharmacy's NPI, and then your information, and you sign and date it just as you would with any other document for an insurance company or for the board. Any questions there? All right. During the enrollment process, we do have our website that is going to have all the two PowerPoints that you'll need. So you'll be able to click there for the enrollment process. And I'm telling you, that's the best tip I can give you is have that up while you're enrolling. We also have a provider service center that is able to help you with your enrollment. I would love to help you, but I really can't because I'm not in enrollment. If you get frustrated, absolutely, I'll get the right person to call you back. But I need you to try the provider service center first because they should be able to get you out of your glitch. If not, Kyle can tell you one phone call and we sort of get it done, don't we? So I do want to, y'all to try to use that resource, but you can always call the pharmacy team. And we do have a new pharmacy mailbox. So I want you to take advantage of this too, because we actually had to use this for Kyle. I'm going to use you for an example. Kyle and I were at a meeting together and Kyle needed some help over at Medicaid. And I said, rather than shoot me an email, shoot it to the pharmacy mailbox at scdhhs.gov. And I can text the girls to tell them to go make sure they got it. They're going to take care of it for you. So use that mailbox for other things too, if you need assistance. So That's something new for us. So filing a claim, that web access tool, it's wonderful. This is one of the 3 ways you can file a claim with South Carolina Medicaid. So you will have to log into the Medicaid portal and you will follow each step as it goes. There is a PowerPoint for that in addition. So there are plenty of resources out there for that. Some helpful tools here is the web tool. It's a tutorial. The physician service manual. We have now been put as pharmacists into the physician service manual. I never thought I'd hear that. We're always in the pharmacy manual, but now we're in the physician services manual. The link to the web tool and the provider resource center. And now I'm going to turn it over to my partner, Julie.
Thanks, Cheryl.
And then maybe if Julie and I can take questions together.
Yeah, that's probably a good idea, because it's gonna overlap. You're gonna see as we get talking here, that I get talking here, that things are going to overlap a little bit. So I'm Julie Hernandez. I'm the pharmacy director with Healthy Blue Medicaid. I'm also a pharmacist by training. So I'm gonna pull everything together here, kind of bring up the end of the presentation, talk a little bit about what Tracy talked about, what Cheryl talked about, how that's gonna work with the MCOs, why it's important that the MCOs are involved in this, and just make sure that we're all on the same page going forward. So I like to give a little bit of overview so we're all on the same page. So we got about 1 million or so, 1.2 million folks in South Carolina that have Medicaid as their insurance, right? And all those benefits, that health benefits that are covered are there on the right. Of those folks, 80% get their benefits through an MCO. So they're not getting their benefits out of Cheryl's house. They're getting their benefits from one of the MCOs. Well, who are these MCOs, right? I think it's always good that we're all on the same page with that too. So I thought the easiest way to do that was to put everybody's logo up on the screen. So I'm sure that's what you recognize instead of the names, right? So there's 5 MCOs currently in the state that service Medicaid members: Absolute Total Care, Healthy Blue, which is where I'm at, Humana, Molina, and then Select Health. Okay, so as we go forward and as I keep talking, I'm kind of up here representing all 5, which is dangerous, because I really can only speak for Healthy Blue, but the other pharmacy directors have given me their permission to speak broadly about all of us as a group. So I want to talk a little bit. I didn't build this fancy thing. One of the pharmacists I work with, who's much younger than me, put this together, but I love it because it's kind of fancy. But I wanted to talk a little bit about an MCO structure so you can kind of get a feel where I'm going with this. So when I started in managed care several years ago, I remember walking into the building and there's 250 employees. And I thought, what the heck do all these people do in here? Like, what are they doing? How does this work? I was brand new to managed care. I had no clue. Here I am, a pharmacist, thinking, well, how am I going to work with all these people? What do they do? And so I realized there's all these different departments within a managed care organization. And the reason why this is important is because right now, you all are sitting under the pharmacy bucket of managed care for us, right? You're processing claims. You're dealing with the pharmacy network under pharmacy. Well, if you choose to work and administer through this Pharmacy Access Act, you're going to be sliding over into the provider side. Kind of what Cheryl talked about. So you're no longer just going to be over there in pharmacy. You're going to be working with provider credentialing, provider relations, claims processing, that kind of stuff. So you're going to get to be in multiple buckets. I know you're super excited about that. You're thinking, oh, dear God, just another mess to have to work with. But I think it's important. And where I'm going with this, and to what Cheryl said earlier, you're going to have to get credentialed with the MCOs. I'm not a credentialer, but I know who is at my organization. So that's kind of where I'm going with this. So let's talk about that, provider credentialing. Cheryl talked at length about getting enrolled with DHHS. At the MCOs, we require, or we ask, or it's required, I should say, that DHHS is the gatekeeper for anybody who wants to service Medicaid members, right? You have to get enrolled with DHHS first. That's step 1. So when Cheryl had on the screen there about what's required to be a provider with DHHS and getting credentialed in that long number that you need to keep track of if you don't finish your credentialing all in one time, you gotta go there first. DHHS is the gatekeeper, okay? We talk We talk a lot, but we talk electronically too between DHHS and the MCOs. We get a provider file from them that tells us who in South Carolina or who across the country has a state Medicaid ID. We get that for pharmacies, so we know what pharmacies are enrolled, and then we get it for all kinds of providers, physicians, nurse practitioners, PAs, chiropractors, everybody. We use it on our medical side, and we use it on our pharmacy side. So if you all are wanting to participate and bill medically for services, you got to be a provider with us too on the medical side. So first step is DHHS. They're the gatekeeper. You get your state Medicaid ID from them. We find out about it through our electronic conversations, and then you enroll with the MCO as a provider. Does that make sense? Don't forget, 80% of our Medicaid folks in South Carolina are at an MCO. So the odds are you're going to have to enroll with an MCO. Just being honest. So what do we need at the MCOs? We are not going to likely ask for as much information as DHHS is going to, because again, they're the gatekeeper, right? They've already kind of cleared you and said, yeah, they're good to go. But we are going to ask for some things like your state Medicaid ID, your pharmacy license, education background, and that kind of stuff. Yes.
Your last point there says malpractice insurance, but Tracy's last slide said that we can't be sued for this. So why
Right.
do we have that?
Yeah, exactly. Good question. They just want to see it that you have it on file. I agree. Yeah.
So with that proof of malpractice insurance, I would say 90+% of the pharmacists are covered under their employer, not individually. Does it have to be individual, or can it be the employer malpractice?
That is a great question, and I don't know the answer to that, but I certainly will find out. Okay. Well, he's going to have mine in a minute because it's going to be up on the screen. So employee, I'm writing this down so I don't forget, or individual. That's a great question, and I'll find out. Okay. Good deal. Okay. Any other questions? Great question. All right. So one thing I do want to point out, Cheryl said earlier for DHHS credentialing, they are kicking butt and doing those in 30 days. We are not at the MCOs. It's going to be more like 60 to 75 days to get credentialed. Just being honest, trying to be transparent there for expectations. So want to make sure y'all know that. How do you go about doing this? There's 5 MCOs, everybody's different, everybody has a different setup, I agree. So what we did is we pulled everything together here on a grid. I've got all the MCOs listed, a link to the provider website, a phone number to somebody from the provider team, and a link to the provider manual. The provider website is going to give you everything that you need. This is the way to go. This is how all of our physicians, PAs, NPs, chiropractors, everybody gets credentialed through the website. Everything is on there that you need. It's a portal. You sign in, provide all the information, upload the information. It's all right there. So if you run into issues, there's a phone number there that I was able to find for a member of the provider team at each of the MCOs that you can reach out to if you do have issues. Certainly want to make sure that you have all that information available. Okay. So you're credentialed, you're ready to roll, you're good to go, you're signed up, you want to perform these services, and you certainly want to get paid, and we want to pay you. So this information should look very identical to what Cheryl talked about. We at the MCOs are following the fee schedule to the T that DHHS is following. We are following it exactly. So whatever DHHS is paying, we're going to pay. Whatever rate DHHS is paying, we are paying the same rate. It's identical. So how do you go about billing claims processing? Well, first of all, you have to know the fee schedule. And this is the same fee schedule that Cheryl talked about. I've got the link up there as well. It will link you into the DHHS website. These are the codes that are payable. Cheryl talked about this a minute ago too. It's exact same codes. These are the diagnosis codes that are payable. Those have all got to match up. So we had a lot of questions about that earlier. Thankfully, we've got those out of the way. But a diagnosis code has got to match up with the CPT code. Then you have to understand how billing is going to work at each MCO. Again, there's 5 MCOs. I get it. We're all going to be a little different, but we all have an online portal for billing. And the vast majority of our providers just bill on this portal. Log in, you create a login, you create a sign up, and you go in and submit the claims that way. All on our website, provider website. Again, we have a whole team of folks at each MCO that does this all day long, works with providers, helps them get credentialed, helps them with their billing, helps them with their claims. Okay, step 3, submitting the claims. This probably isn't gonna make any sense to anybody right now, but when you start doing this, you're gonna say, oh, I remember she said 3 things. 3 things have to be on there for it to be a good claim. The CPT code, it has to be one of these, a diagnosis code, and the FP or family planning modifier has to be on for each claim. It will kick out if it doesn't have those 3. If you transpose numbers, it'll kick out because we have configured our system to only pay these codes. So a lot of work has gone in on the back end to ensure that these codes will pay when a pharmacist submits, but only these codes. Okay. Pharmacy will be the place of service. That's another thing the claim will ask. Has to be a pharmacy. Can't be the emergency room. It can't be an infusion center. It's got to be a pharmacy. Makes sense, right? Common sense there. Pharmacists will bill as rendering, and the pharmacy will file as billing or pay to. Just like what Cheryl talked about. It's going to mirror exactly. Yes.
So obviously, this is completely backwards to what we're all used to.
Yes.
Right? I mean, we bill as a facility, and if it happens to have the pharmacist name on it, great, we'll go with that.
Right.
What is the logic behind, I guess from our standpoint, reversing it, but is it because in the medical field, it is reversed?
Right, exactly. We're mirroring kind of how the setup is on the medical side, how medical billing occurs today. Exactly.
Obviously, people are going from pharmacy to pharmacy.
Absolutely.
They work here today and they
Right.
work here next week and,
Right.
and all of those things. So to go through this whole process to get it done, and then your pharmacist leaves or retires or whatever,
Yep.
you got to start all over.
Yeah. And that's where we kind of talked about initially when we came up, when this legislation was passed, what can we do to make it easiest for the pharmacist? Can we not just bill these under the pharmacy on the PBM platform, right? So you're not having to go into another system to submit billing claims, right? But unfortunately, the PBM systems aren't set up for that, right? There's no way to bill these codes. Now, do I think that's coming sometime in the future? I do. As this becomes more popular across the nation and more states are adopting this and having pharmacists be able to bill for these services, ideally, that's the way it would be done. Then you're in one system and it just gets transmitted. Unfortunately, we can't.
I think what I'm asking is just on this side of the fence.
Mhm.
We do medical billing. We do durable medical equipment. We understand medical billing. It's not new to us. But on this side of the fence, it has to be the provider billing, not the facility, I guess.
Right.
That's
Because-
what we're-
Right, because the provider, yeah, because the pharmacist it has to be the registered provider, yes.
And that's the same whether it's a doctor's office or an emergency room
Correct.
or whatever. So if a doctor, and I hate to beat this, but I'm just trying to get my brain around it. Let's say a doctor was working at Lexington Medical Center and they're credentialed and they're billing for all of that.
Mhm.
And now they're working for Prisma
Mhm.
next month or whatever. So are they, the patients, do they have to be credentialed with all the payers before they can actually see patients and they just get billed?
Yes, they have to be credentialed with the health plan, yes. Absolutely.
And they carry that credentialing wherever they go.
They can't, yeah, they just keep it with
They
them, right?
just have to report that they're at a new facility.
Right, exactly. Yep, no, they have to get credentialed with the health plan.
Sorry.
No, that's a good question. That's a good question. Yeah, my husband's a physician and he's credentialed with da-da-da-da-da-da-da-da-da, and now he's at the VA and he still has all this credentialing at all the Medicaid plans, but he's not practicing in that area anymore. So yeah, they just keep their credentialing with them. Nope, good question. Anybody else? Okay. So I kind of want to close with this, and I know my presentation was very broad. Again, I'm up here representing 5 MCOs, so I can't get into the devil of details of everything. But I want to let you know and want to make sure you understand that we're here to support at the MCOs. We want to make sure that you have the resources that you need. So foremost, at the top of the list, again, we have key people at our organizations that do this all day long, the provider team. You know, they do credentialing, they do billing, they do claims. Those are your experts. It's not me. I can be helpful, but I'm certainly not the expert. Use the provider website, that's there for you as well. I included all those links, so you have that at your fingertips. But when you come to a roadblock and you can't get what you need, reach out to the pharmacy director. We're here to help. I've got everybody's emails up there. We want to make sure you reach out. Deborah Bowers just reached out to me yesterday. She was trying to get a hold of somebody. She couldn't get what she needed. She sent me an email. Done. I connected her to the right person. So we are happy to do that. We are pharmacists too. We are anxious to see this bill and see folks implement this. So we certainly don't want to put up any barriers for you to not be able to get reimbursed for your services. So I understand that. One thing I will say is this is new, right? It's new for all of us. A lot of work has gone in. I mean, I can't even tell you how many hours we spent talking about this with DHHS. How are we going to do this? Can we do it on the pharmacy side? Do we have to do it on the medical side? You know, all this back and forth, the configuration behind the scenes to make sure the claims pay. There's been a lot of effort put in. There's going to be glitches, guys. It's not going to be perfect. So when you run into those glitches and you run into those issues, please reach out. We want to make sure that you feel supported and that you can get the help that you need.